The TMJ TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ TMD Demystified podcast.
Hello, TMD warriors. We're here for another episode of TMD Demystified. I am Tony Urbanic. It's a rainy morning here in Brentwood, Tennessee, and I had a good night's sleep and raring to go. Today's topic, we're going to talk about something. All these topics are important, frankly. To me, they're important. I hope that you're getting something out of it. If you pay attention, I think you will get something out of it. Today's topic, I think, is very relevant, very important as far as fact-checking the things that are used and have been used for decades to treat TMD that make no sense. I'm going to go over this very carefully. If you are an orthodontist, you may be insulted by some of the things I say, and my intention is not to insult my orthodontic colleagues. I have great appreciation for orthodontics and my orthodontic colleagues. They maintain a skill that I don't have. I'm a surgeon, and I think that they do a great job. My children and my grandchildren benefit by orthodontic care. But in my 50 years treating functional malocclusions and working with orthodontics, I find that orthodontists in general, there are exceptions, do not understand facial growth and development generally, and frequently overlook the relationship of the occlusion in the teeth to the temporomandibular joint. Now, I don't want to go deeper into that. I can probably, if I think about it, come up with 100 different examples in my career where patient care has been stymied, complicated, made difficult, or not done at all because of complications, let's just say communication complications voiced by some of my orthodontic colleagues. But today's episode is entitled, Fact-Checking TMD TMJ, Orthodontics to Treat TMD. In other words, we're going to fact-check the use of orthodontics to treat TMD, So, as I've said before, I do a weekly blog, which is a written blog that I produce every Sunday night that goes distributed to our network providers. It's distributed to our email list. It's distributed to all of our referral sources here in Middle Tennessee, which are now probably over 900. My last number was right at 900 referral sources who refer us TMD patients in Middle Tennessee, which include 2/3 of them from the dental community and 1/3 of them from the medical community of various specialties, various general nature doctors, nurse practitioners, physician's assistants, chiropractors, physical therapists here in Middle Tennessee who send us TMD patients to treat non-surgically. But anyway, my weekly blog, which is also entitled, parallels my weekly episode on TMD Demystified, directed to primarily dentists, and the blog is directed primarily to the public and public information, with the same title, Fact-Checking TMD TMJ Orthodontic Treatment for TMD. I'd like to just read the first paragraph and we'll go from there. first paragraph, I think, is concise, and so I'm not going to try to duplicate it other than to read it. It may surprise you, but treating the symptoms of TMD, TMJ using braces on the teeth has been promoted by orthodontics almost as long as TMD, temporomandibular joint disorder, has been identified as a disease. If ever there was an example of the adage, if the only tool you have is a hammer, everything else looks like a nail, orthodontists treating TMD takes the cake. That is my opinion, and I'm entitled to it. Now, again, I apologize if I have offended an orthodontic colleague, but I have witnessed hundreds and hundreds in my 50-year, rather lengthy career as an oral and maxillofacial surgeon, 36 of them treating TMD surgically, 36 years and over 2,000 cases. In the past 14 years, treating the TMD non-surgically, I have witnessed hundreds and hundreds and hundreds of cases of patients coming in with the history of being told by an orthodontist that what they need is orthodontics to treat their TMD symptoms, which include, as you well know, if you listen to any of my episodes, a long list of disparate symptoms, disparate meaning they don't seem to be connected at all, of symptoms of headache, earache, jaw pain, neck pain, tinnitus, subjective hearing loss, vertigo, upper back and shoulder pain, arm, hand, finger tingling and numbness, and various kinds of jaw locking. Anyway, those are the disparate symptoms, and the orthodontist telling patients with one or more of those symptoms that the solution is to get their teeth straightened. So hundreds and hundreds of cases have I run across my path, that being told by an orthodontist. Now let's try to keep it simple. I won't keep it long. Once I've made my point, I'm going to wrap it up. But we're fact checking here. So if you ask an orthodontist why he believes that straightening the teeth is going to handle or make one or more of those symptoms diminish or go away, the answer will be something like, well, we know that malocclusion, that is high spots or different kinds of problems with the occlusion, stimulates bruxism. It is well established that bruxism is one of the three primary causes of damage to the temporomandibular joint. This is true. This is fact. The other three causes are acute trauma of various kinds at various times in life. It can be early in life. It can even be during birth. That's a good example of a topic I need to cover later on regarding TMD, that is damage to the temporomandibular joint during birth. But the point is, acute trauma at any point in life can cause damage to the temporomandibular joint that can ultimately bring on those disparate symptoms. And then the third cause is functional malocclusions. Functional malocclusions, of which can be major or even minor, well, not minor, moderate, because patients can accommodate minor functional malocclusions if they're really minor. But the point is, you will hear from the orthodontist, how in the heck does straightening your teeth decrease the disparate symptoms of TMD? And the answer will be, well, occlusion, a malocclusion of whatever kind he's looking at, will stimulate bruxism, and we know bruxism damages the joint, which creates the chronic inflammation, which creates the symptoms, which the orthodontists don't know that part of it, but the malocclusion will stimulate bruxism. Well, that is not fact. Malocclusion, even if you have a high spot, I mean, the general dentist, we all know, I went to dental school, if you have a high spot, the patient will focus on it. And if they are bruxism, they'll focus on that one spot, that one high crown, day and night. And at night, they'll brux on it. They'll brux on it. They'll brux on it. But it isn't the high spot that is causing the bruxism. The fact is, well known, well established, statistically proven that bruxism is created somehow, we don't know how exactly, by anxiety and stress. And if you want to add worry, stressors. That is statistically proven, and it is also intuitively known by everybody. If you live on planet Earth, you have to deal with stress and anxiety. And some people do better than others in handling that. And that, again, is a whole other topic and why that might be. But that is not my area to discuss today. But if you live on planet Earth, you will be stressed. You will have anxious times and worry, which somehow converts through the central nervous system into constant motion of the jaw muscles, which are then called bruxism. And bruxism can occur actually day or night, does not, just so we're really clear here. Bruxism is clenching and or grinding during the night or the day, or both. It does not have to be noisy. It can be silent with just clenching. My primary mentor in oral and maxillofacial surgery, Dr. David Hall, and for anyone who went through my program at Vanderbilt with David Hall back in the early days of minting many program directors in oral and maxillofacial surgery and professors in our profession. Dr. Hall was well known for studying you when you were trying to answer something, and you could watch his masseter muscles just move as he looked at you. It was somewhat intimidating, but anyway, I'm getting off point. Clenching you don't have to make any noise at all. All right. So clenching and grinding, bruxism is associated with, intuitively and statistically proven, anxiety and stress, not high points on the occlusion. High points on the occlusion will be the area where you will like brux constantly, night or day. And so when the orthodontist says that that's the reason he is doing orthodontics to treat TMD symptoms, it doesn't hold water. It's not factually true. So the truth is that bruxism is associated with stress and anxiety, which is a mental condition, maybe even in some cases a mental disorder where it transitions from a mental condition to a mental disorder. I'm not going to try to discuss that either. But that is the fact. Bruxism is associated with stress and anxiety. Everybody has stressors. Half the population bruxes. Not all of those develop TMD symptoms, but literally half the population bruxes at some time or constantly during their life. And then you develop symptoms, or you develop things that are indicative of a bruxism, like tori. When you see tori, mandibular tori, lingual tori, palatal tori, or labial in the maxilla or mandible exostoses, they're all basically hard bone laid down around the teeth due to bruxism. And that's one of the facts that most young dental students don't learn in dental school, that tori are associated with bruxism. So when you open somebody's mouth and you see any of those tori or exostosis, you can be assured that that patient has a history of bruxism. That's one of the reasons I can tell you that generally half the population, clenches or grinds their teeth, has bruxism. So the fact is that orthodontists should not be primarily treating TMD with orthodontics. Now, I am not saying, and hear me clear on this, I am not saying that the orthodontist has no part to play in treating a patient with TMD. Again, this is clearly identified in the blog that I just wrote 2 days ago. Actually, my esteemed orthodontic colleagues have a very important part to play in treating TMD, because once you actually decrease the symptoms to the point where the patient is happy, the symptoms are diminished or totally gone, then it's time to address if they have a functional malocclusion. Remember, it's one of the primary causes of damage to the joint. If they have a functional malocclusion, then that needs to be treated. Now, some functional malocclusions, if they aren't too great, can be treated with orthodontics alone. And a functional malocclusion means some type of difference between centric occlusion and centric relation, where the condyle fits nice in the fossa. Most of the population, every member of the population has a difference between CO and CR. Everyone, unless it's been already fixed. If you have a natural occlusion, you are going to have somewhat of a difference between centric occlusion and centric relation, and most people can accommodate small differences between centric occlusion and centric relation with no symptoms, no problems. They don't even know that they have two separate bites. But on occasion, when that bite begins to change to the point where it increases, and it doesn't have to be large, as a maxillofacial surgeon, I was used to fixing large changes in function in COCR problems with large prognathisms, class 2 occlusions, facial disharmonies, crooked faces. They are all functional malocclusions, facial growth anomalies. So the orthodontist, once the patient is out of symptoms, and if you're out of symptoms, then you are fixed, cured, quote, cured, in quotes. Then you can go on to, if necessary, fix their functional malocclusion. And orthodontics sometimes, if it's not a great difference, can match much closer. You don't have to be exact match between CO and CR is not necessary, but to get CO much, much closer to CR, at which point it no longer becomes a functional malocclusion. And if the COCR problem is great, class 2, class 3, then it's a combination of orthodontics and oral and maxillofacial surgery and orthognathic surgery, of which I've done well over, I mean, quit counting those, somewhere between 2,000 and 3,000 cases in my career of orthognathic surgery. And that doesn't count any temporomandibular joint surgery or microneural reconstruction or cleft palate work, just orthognathic. So the orthodontist does have a very, very important role to play in treating TMD patients because, again, if you can take away the cause of the damage, now you're not going to repair the joint itself. You're not trying to repair a dislocated disc or a disc with a hole in it or whatever. But all you're trying to do is get the CO much closer to CR, whether it be orthodontics alone or orthodontics plus orthognathic surgery. Then you've taken away that cause of damage to the temporomandibular joint. So, as I guess a bone to be thrown to my orthodontic colleagues, I appreciate what you're able to do in the rehabilitation, not the primary treatment, but in the rehabilitation of a TMD patient. Extremely important and appreciated. I just, before I wrap it up, I do want to make one point. Again, I have the experience and enjoy the experience every week of seeing one day of patients per week. And yesterday, again, they all make an impression on me. I had a middle-aged woman with all the usual symptoms, came in for consultation, and as most of the cases present, she had a really strong history of being run around in circles for years and years about her symptoms of TMD by just about everybody, by the dentist, by her PCP, a couple walk-in clinics. She began having a history of her symptoms early on. She was a patient, as I found out, and I got her history. This was just yesterday. And as I did the examination in history, I found out that she had orthodontic treatment as a young child, which to her, she expressed extremely traumatic for her. And I'm kind of thinking back, I think she said she was around age 10. But what I was looking at in this patient was a huge prognathic mandible. I mean, she was, let's see, she was about 35, and her mandible was out a good 3/4 of an inch. And she told me how she had been seen by an orthodontist at age 10 who put her into a head strap, maybe not a head frame, but she described to me how traumatic it was because she had a strap on her chin and a halo or a headpiece, and he applied significant force on the mandible as a 10-year-old to push. I mean, the theory and the action is obvious. I didn't talk to this doctor, but I assume what he was thinking, that if he could put enough force on the mandible, it would fix her tremendous prognosticism, which showed up as early as age 10, which would be logical. With a prog this big, you'd be able to notice it probably before age 10 significantly. And she told me how traumatic this was for her life, and she didn't carry on at all after that. And then when I gained the rest of the history, she had been seen by a neurologist and had a multi-thousand-dollar workup from the neurologist about her headaches and her facial pain, and nobody could figure out how all the drugs she was put on, and nothing worked. Again, this went on for a decade or more in her 20s and 30s. And the neurologist finally, and I don't know why a neurologist, I guess around here they're kind of tuned into TMD because of the action here in our practice, but the neurologist ordered a temporomandibular joint MRI. And she was very well versed on it. She didn't show me the report, but she said the MRI showed that on one side the disc was totally dislocated, and on the other side the disc had a hole worn in it. I'm laughing. It was terrible. It's terrible. But I can tell you that didn't happen magically. The fact that she had a dislocated disc, which is almost always anterior. They can be medial and lateral or combination. But the disc itself was anterior dislocated and stuck, and the other side had a hole in it. Definitely had something to do with pushing on your chin with a head strap when you're 10 years old. Fortunately, she didn't put herself through more than a few months of doing that, but she said it was very traumatic. And she finally came in to see us, and in short order, we went through the consultation, and she's going into treatment. And I can tell you that even with the big class 3, we put her into one of these devices for 24/7 for 2 months, and then nighttime only for a few months. And she'll get relief of the symptoms, at which point I've already had the discussion with her that she needs a combination of orthodontics and oral and maxillofacial surgery to correct her significant mandibular prognathism. And again, she was 35. You would really think that somewhere along the line, someone knowledgeable enough and with enough character and with enough certainty would address her and explain to her the relationship between a big prog, functional malocclusion, and developing TMD symptoms and how to fix it properly. That just happened Monday. It's a good story. There was more to her story. She had seen other doctors, dentists. She didn't say that she had seen an oral and maxillofacial surgeon. She did say, I have to admit, she did say early in the discussion that she had been told that she needed to go to an oral surgeon and get her jaw broke, which that scares everybody. And, all right, enough said about that. So regarding this topic today, fact checking, part 5, fact checking TMD, TMJ, orthodontic treatment for TMD. It has great value in the rehabilitation of a functional malocclusion. It has no value in the primary treatment of TMD. Orthodontics does not. And I would hope, using logic and introspection from my orthodontic colleagues, that at least the orthodontic colleagues get access to this information that I'm giving, that they will look this over and admit that if they had been operating orthodontic treatment, promoting orthodontic treatment under false pretenses, that they'll clean up their act. With that said, I look forward to the next time we can speak. We will continue this series for a while. I don't know how long, series on fact-checking TMD, TMJ treatments that just don't hold water, that they're just not factual. I did not intend to get into this arena. I did not intend to get into this arena, but 14 years ago, I decided to do my own research on what was really going on about TMD, how it came to be, how come nobody could figure this out, and all these areas of smoke and mirror and nonsense have been applied to the treatment of TMD. And so now I'm kind of stuck. I figured out what's really going on, and it's now my responsibility to pass it on. With that said, I look forward to the next time that you're here. I'm Tony Urbanik, and this is TMD Demystified.